Thanks very much, Richard. So yes, I am zooming in from Treaty 1 territory in beautiful Winnipeg. So thank you for that introduction, and thank you for inviting me to participate in the BC panel and the Primary Care 101 presentation. I think this is really important work. In my position as president of the National College, I have been involved with the OurCare project since its onset. And so I'm really looking forward now to hearing and learning what you have to say about healthcare in British Columbia. And just a couple more things about me. So I'm a family physician. I've been practicing for over 25 years. I did my training in Kingston, Ontario at Queen's, and I moved to British Columbia in 2001, where I've been practicing in a teaching clinic out on Point Grey at UBC since then. As said, I am an associate professor and associate head in the department. And the reason I do that is because teaching learners has always been a passion of mine. And so there's one piece that wasn't mentioned is I'm also the Associate Vice President Health. I have an interim job in the Office of the Vice President Health, and you say, what's that? And it's a unit that actually covers the 14 health professional programs at UBC. And that's another area of work that I'm really passionate about, and that's collaborative care and team-based care. So let's go on to the presentation. Just a quick note, I have nothing to disclose. As I've said, I'm a full-time employee of the University of British Columbia. Next slide, please. So Richard and Tara have asked me to cover the following questions. How healthy are we in British Columbia and Canada? What is primary care, and how is it different from primary health care, secondary care, and tertiary care? And why is primary care so important? And I'll end just with a little bit about the crisis in primary care from my perspective as a family physician in British Columbia. So I hope to leave a lot of time for questions. So today, how healthy are British Columbians? Next slide. So there are approximately 5.5 million people living in British Columbia, and they're broadly distributed to every corner of the province. But still, you'll see that more than half are living in large urban centers, which on the left in the map, you'll see the bright red and orangey areas. And I share this information with you because healthcare will look different across the province. So healthcare in Vancouver will look very different than healthcare in Fort St. John, or very different from healthcare in Kelowna or Kamloops and so on. And a colleague of mine often says, you know, once you've seen one rural community in British Columbia, you've seen one rural community in British Columbia. So, and then if we look to the other part of this slide on the right-hand side, it shows the diversity of our population. And we have a rich mix of cultures in British Columbia with a wide variety of healthcare needs and values. And British Columbia is actually the most diverse province in Canada. And so again, this diversity impacts what healthcare priorities for the different communities are across British Columbia. Next slide, please. So this slide shows the age distribution of our population. And as you go up the scale, up the bars, that shows people getting older. And then as you go further away from the center line, it means that there are more people in that age group, and males are on the left of that central bar and females are on the right of that central bar. So the middle graph shows about where we are now. This is a 2021 statistic. And the purple line, and I've only included the purple line on this particular one, is BC, and then the bars show compared to Canada. So it's fairly consistent. And you'll see the average age, which is typed out at the bottom there, is 42.8 years old. The graph to the left of center is from 2001, and it shows the average age of 38.4 years. And then the graph to the right is 2043, and the average age is 46.7. So as you can see, people are getting older. Now, as we get older, we don't necessarily become unwell. However, it does in general mean that we do have different conditions. We develop arthritis, we may have high blood pressure and so on. And so we may have a couple of conditions or a few, the older we get, we may collect a few more conditions. And we're managing those conditions, and our healthcare will look a little different from when we were in our 20s and 30s. And so that's the way population age impacts what we consider on health and healthcare. So the next one is other factors that we know influence our health. So pretty well known: smoking, excess alcohol, physical activity, and a diet low in fruits and vegetables. And so these are critical factors in primary care. They play an important role in our health. And we probably don't pay enough attention to these individually, but also in healthcare. And their important role, if we did pay attention to them, in preventing disease. And so by not paying attention to them, we end up managing them downstream when they've negatively impacted our health. Next slide. Oh, there we go. So, oh, this one isn't. Yeah, okay, good. These are just two factors that I want to highlight again with respect to their impact on health. So the last one was modifiable behaviors that impact our health. And this one are bigger factors that are less easily modified. So the first, the map of Canada on the left-hand side shows that your life expectancy is influenced by where you live. And you can see a variation across Canada. You can see an almost 10-year difference between the different regions in Canada. And then the second factor outlined in the graph on the right-hand side shows the impact of income or socioeconomic status on life expectancy. And it also actually highlights gender differences as well. So again, these less modifiable factors impact our health, and they need to be considered when we're designing healthcare programs for different provinces and different communities. Next slide, please. So, what are the leading causes of death in BC and Canada? And this slide just shows that there are 1 in 4 deaths of Canadians younger than 75 are from preventable or treatable conditions. So in British Columbia, there are 179 avoidable deaths per 100,000 people per year. And on the right-hand side, you can see that these factors, these preventable or treatable factors, are impacting males far more than they're impacting females. Next slide, please. So what are the leading causes of death in British Columbia? This slide outlines the top 15 causes of death, and it shows us that the vast majority are preventable. I've highlighted 2 areas that continue to challenge us: the COVID pandemic and also illicit drug use, which is particularly important and challenging and a big consideration for primary care in British Columbia. And just next slide, please. One more comment on COVID, because the pandemic has impacted us so significantly. I think it's important just to spend a minute on it. This slide shows deaths related to COVID. And in general, Canada did well in managing the acute phase of the pandemic. Japan had the lowest number, as you can see on this graph. And then Canada was down there as well, with relatively lower numbers of deaths internationally. But we also know that COVID has a significant impact on health beyond simply measuring a death rate. So while we did well in the acute phase, we know that healthcare programs that we develop going forwards need to include the considerations for not only additional waves of acute illness, but also the longer term health impacts on mental health, addictions, and even long COVID. My current worldwide data shows that nearly 15% of people who have had COVID develop long COVID. We're also starting to see that some of those heart impacts of acute COVID are actually having some longer term impacts on heart health. Similarly, lung impacts and respiratory impacts of acute COVID. This is different than long COVID, but are actually changing some of our lung health conditions and our respiratory conditions. And all of this to say it's also layered on the impact the pandemic has had on our healthcare workforce. We're part of the population as well. And so we have to consider these sort of overall impacts, not just the deaths related to COVID, when we're considering the healthcare system moving forwards. So what is primary care? That was a bit of a snapshot of the factors influencing our health. It's by no means the full picture. And so now we're going to move on to what are we considering when we're thinking about what's important to us in designing primary care. So what is primary care? So this chart is from the NHS in the United Kingdom. And I like it because it really outlines the sort of 4 quadrants of healthcare that we think of, and it's fairly simplified. And the bottom left is community health services. And these are things like public health immunization clinics, nursing stations in rural and remote communities, home care, Planned Parenthood, sexual health clinics. Those are what we would consider broader community level services. We would think of this as primary health care. Then you go to the top left, and while this is labeled primary care in the UK, this would be primary care, and it includes dental care, eye care, and community pharmacies, in addition to what we would consider family practice or general practice. In Canada, again, the dental care, the eye care, and the community pharmacies would probably still be within what we would call primary health care, which is slightly broader. And what we think of primary care is really the care that we get from our family doctor's office or a nurse practitioner's office. And so that's really what we're thinking of when we talk about primary care. On the top right, from primary care, you move to a little bit more urgent and emergent care points. So the emergency department, the urgent care center, the urgent mental health care, and most hospital care. So that's what we would call secondary care. And then the bottom right is even more specialized, and that's hospital-based care like neurosurgery, trauma care, intensive care, orthopedic surgery, cardiac care. And so I hope this has explained it well. Primary care is really that top left. And in Canada, it's just the part really that you get in your family practice or nurse practitioner's office. Next slide, please. So, and these are the principles that also help define primary care in Canada. And we talk about the 4 C's, and they're really, as I say, what defines us and underlies what primary care is and what we do as primary care providers. So you'll note, though, that there's a starred point at the top that doesn't fall into the 4 C's. And this is even, this is a foundational element of all primary care, and that is the relationship with the patient, and our aim of ensuring that we provide truly patient-centered care. So the relationship and that patient-centered piece is really the foundational element. Over time, we get to know you, you get to know us, we get to know your family, your community, your health care issues, but also your hopes and other challenges. And so this is the part of being a family doctor that is the most rewarding, and it's often the part of the job that draws medical students into family practice in the first place, and away from other disciplines of medicine. So let's get on to the 4 key principles of primary care. The first is first contact. So the first contact in primary care is the first point of access to the healthcare system, regardless of whether of what the problem is. It's where you're initially assessed, and usually, most of the time, it's where you receive your treatment or management plan. Sometimes we transfer on to, or we transition your care to secondary care or tertiary care, but that's less common. So primary care is that first contact for most things. It's comprehensive. So that's the second C. It's not focused on a single body part or body system. So I'm not like a cardiologist or a respirologist or a neurologist. We see the whole patient. We treat them holistically, and we see them across every age group. The third principle is continuity, and you may have heard the expression from cradle to grave. We often hear from womb to tomb. And as I've said, this relationship piece, it develops over time. And we see you, when we commit, when we accept a patient into our practice in primary care, we accept them for their lifetime. So a 30, 40, 50-year relationship. And we keep that story. It's also about informational continuity. So as we are shifting, and we'll talk about team-based care soon, as we shift to teams, we make sure that that information and your story is shared amongst all the healthcare providers that we work with. And the final C is coordination. And that is that not only are we the first point of contact, providing comprehensive continuity of care, we also coordinate with secondary, tertiary care, community care, and we pull together all of that information, and we keep that all together and help coordinate your care throughout the system. Next slide, please. So I won't spend a lot of time on this one because it's very academic, I think. However, I think it really clearly depicts that primary care is built on a foundation of evidence-based components, each block representing an important component that's needed to really support effective and efficient primary care. And so when we hear politicians saying, oh, we're going to expand medical students, number of seats for medical school and number of seats for residency programs, they're addressing one area, they're increasing numbers. But without addressing all of the other blocks, the efficiencies of the primary care system really won't be achieved. And so I think just showing this slide and identifying or seeing these 10 building blocks of effective primary care is important, because I have a feeling you're going to be talking about some of these concepts as you go through your work on the panel. Next slide, please. So why is primary care important? So primary care is important, you know, because, sorry, next slide, please. There we go. So this is really sort of capturing some of the things that why primary care is important. And that is that you'll see. So this is Ontario data. It's fairly consistent across provinces. And so what it is it shows all of the services, the healthcare services that happen in one day this is Ontario. And it highlights that over 50% of them, that dark blue area, is primary care. So those are the visits to the family doctor's office or the nurse practitioner's clinic. And this is the first point of contact. And it's compared to number of x-rays, a number of emergency visits, number of CTs and MRIs, number of hospital visits. And then in that tiny little corner is the number of hip and knee surgeries during the day. So it really demonstrates that if you take away primary care, and we currently are seeing a challenge with accessing primary care, where do all of those visits end up? Well, we've noticed that they end up in emergency departments and results in an overflow in emergency departments and urgent primary care settings, and even specialist offices are trying to figure out how to manage primary care problems, even though they're actually a specialist focusing in on, the heart or the lungs or whatever. So we know that we tend to focus, and policymakers tend to default to focusing on supporting acute care. Let's build more emergency departments. Let's build more urgent primary care centers. Let's build more hospitals. But we know that if we don't actually build a strong primary care foundation, we're really not going to have efficient secondary and tertiary care. And that's going to prevent people who really need access to the emergency department and the hospital and testing and investigations. It's going to limit their access or delay their access. So this is a part about that first contact and really serving to care for the majority of patients in the system every day. Next slide, please. Another piece of the sort of why is primary care important, and this depicts the research that was done around continuity, this other C of a foundational element of primary care. And this research was done in Alberta, and it looked at the impact of continuity on different aspects of care. And they found 64 studies that looked at different impacts on continuity of care. And they found that continuity overall improved a variety of aspects of care. So for example, they'll look at, one of them says 16 studies looked at quality, and 10 out of 16 showed a distinct improvement in quality of care when there was a continuous relationship with a primary care provider. 15 of 16 showed improvements in satisfaction, 16 of 17 showed cost savings when there was a continuous relationship with a primary care provider. So primary care is important, not because of the first contact and that comprehensive care and that quarterbacking of care, but also that continuity seems to drive quality. It actually prevents illness and disease progression. It improves satisfaction, and it reduces cost. So primary care in British Columbia, how is it set up? Next slide. Okay, so there are two big things, areas of consideration when we think about how primary care is organized. So the first is a payment model, and the second is a practice model. In looking at the payment model, the primary care providers, family doctors and nurse practitioners in general are paid on contract with the Ministry of Health. And there are three main types of contracts: fee-for-service, salary, and capitation. And now we're starting to see that there are different mixes of these three that fall into sort of blended contracts. And I'm going to talk more about the payment model, but that's the basics. That's the basic organization with respect to payment. I see a question about capitation. Is a payment to the family doctor per patient that is rostered or registered in their practice? It's an annual payment. So you could see your family doctor once a year and they would get a payment. You could see them 10 times a year and they would get the same payment. So that's capitation. The next big way that sort of describes organization is the practice model. So in the past, family physicians were mainly solo practice. Then over the past couple decades, we've started to work together in groups to share the load and practice costs and on-call services. And some groups may still work fairly independently. They won't share records. They don't really cross-cover patients, that type of thing. And some groups actually do share records and share call and do cover each other's patients for vacations and things like that. And then another practice model, which has grown more in other provinces than in British Columbia, is the managed care model, which you can think of clinics that you'll find in Walmart, Superstore, large chain pharmacies, where the business aspect of the practice is managed by the store. And the family physicians just provide, or nurse practitioners come in, provide a shift of care, and then they're done for the day. And then the final type of sort of practice model that's growing in British Columbia and across Canada is team-based care, where groups of different health professionals are working together, same patient record, same population of patients. So team-based care, teams are dependent usually on the community they're in, and can include nurses, pharmacists, dietitians, mental health counselors, a variety of different health professionals. And they have been rolling out in British Columbia, and you may have heard of them as community health centers, patient medical homes or primary care networks, urgent primary care centers, and First Nation health centers, and nurse practitioner-led clinics. So next slide, please. Just a little bit more about the payment model. And the reason why is because it's interesting. Of payment model and practice model, the payment model actually drives the practice model. So there are some payment models that will support solo and group practice, and there are some payment models that will support team-based care. So what we've seen is that 85% of new graduates prefer the payment model that supports team-based care. So that's a salaried model, some type of salaried model. And yet still 71% of physicians are paid by fee-for-service across the country and in British Columbia. There are enhancements to this fee-for-service model that can pay to hire other health professionals into the program. And so we have seen some of those incentives. However, in general, fee-for-service is one of those volume drivers. It drives seeing patients quickly so that you can bill for the service and pay for your practice. And so we're really pushing for salaried models that improve, that add to the time that you can spend with your patient and have been shown to drive quality of care. Now, we have seen that some capitation models actually reduce volume and then actually decrease access. So what we're finding as we go through these different fee-for-service models and salaried models, we seem to want to blend something that pushes volume so that we see patients but provides us enough time to provide the care that they need. And so a blend of a bit of compensation model. And that's actually the model that's rolled out in British Columbia as of February 1st. They introduced a blended compensation model that has salary, capitation, and fee-for-service blended together. Next slide, please. I'm going to quickly go through this one. And this is an evidence-based idea for what primary care could look like in Canada. It's not a set model, but it's different criteria that should really build a strong primary care. And examples include family health teams in Ontario, primary care hubs. In Quebec, they have the Groupe de Médecins de Famille. And in BC, we've actually used the term patient medical home, and they've been implemented in primary care networks. And we see a lot of these characteristics also in our community health centers. It really does highlight the 4 C's. Again, next slide, please. And so we've seen in British Columbia, the implementation of the patient's medical home model within primary care networks. So that's a transition to a team-based, patient-centered primary care model. And these have been supported initially on the rollout with enhanced fee-for-service, and now they're being supported by this blended model of payment. And so we've transitioned both our payment model, and we've also looked at we're transitioning our practice model, although still only 25% of our population actually is engaged in this new way of working in primary care. However, there's hope. The next slide. Yeah, so these are the 59 primary care networks that have been implemented across the province. And so while only 25% of the population still is engaged with this and attached to perhaps a primary care network, we are continuing to work on building out these models of care. And last little bit, and then I'll open it up to questions, and that is, why do we have such a crisis in healthcare today? So quickly, about 1 million people in British Columbia are without a family doctor or nurse practitioner. And we know that the pandemic has exacerbated our gaps in care, but not all of the health system challenges can be attributed to the pandemic. Next slide, please. Healthcare providers feel like they've been on a treadmill for the past 3 years, but instead of slowing down as we're evolving out of the pandemic, it seems like we're going faster and faster. And part of that is what I've talked about. Patients are getting older, they're getting more conditions, and their care is more complex. So they have more layers to their healthcare. At the same time, the system has evolved and become more complex. There are more subspecialties, there are more diagnostics, there are more therapeutics. So navigating the health system, both as a patient and as a provider, has become more challenging. And managing this complexity day in and day out has really added to that level of exhaustion. And so we're actually at an all-time high in the number of healthcare workers identifying that they're burnt out. And we have about a 30% vacancy rate of all health professions across BC, but also across Canada and actually around the world. So it's a challenging time for healthcare. Next slide, please. This is layered in with some of the other things that have been impacting health and making healthcare more complex. We have forest fires and all the respiratory conditions related to smoke. We have heat domes and heat exhaustion, heat stroke, heat-related deaths. We have floods and the displacement of people and disruption of access to care. And then we don't think about the secondary impacts of that is who can exercise during forest fire season or a heat dome, who can maintain a healthy diet when you've been displaced and you're just looking for a warm bed and you'll take whatever food is brought to a shelter. So these are really the primary adding to the healthcare crisis. Next slide, please. I don't have to tell you as well, BC leads the nation in deaths for opioid overdose. And this is the 6th anniversary of our documenting the number of deaths related to our opioid crisis, and a real challenge for designing primary care and figuring that out. Next slide, please. And again, downstream effects, long surgical wait lists, delayed cancer diagnosis and treatment, interrupted transformation, and emergency room overcrowding, hospital overcrowding, long-term care deaths, and challenges with staffing. So, and I can say as a teacher in the medical system, our learners are seeing this strain. And as a result, fewer and fewer of them are going into medicine, fewer and fewer of them are going into family medicine. Okay, next slide, please. So that is a brief outline of primary care in British Columbia, a complex puzzle, and we need your input on how to piece together some of the solutions. And I didn't catch nearly any of the questions. I just saw one flash up on my screen, so I'm prepared to answer some questions.